Hello everyone, in this video we are going to talk about forceps and vacuum. Now both of them are the methods of assisted vaginal birth. Right? Now this is a hot topic. If you go for the obstetric viva, if you go for table examination, if you go for the any kind of cases, this thing will be there. So it's very important. Now most of the students, they concentrate on the techniques of forceps and vacuum. They try to remember all the kind of information about the technique, but what they forget is about the complication. Now examiner wants you to be a doctor and not to be just a skilled person. Okay, so if you are a doctor, if you are going to use either forceps or vacuum, you need to discuss this thing with the patients before. The complications are important part of assisted vaginal birth, and patients needs to know what are the complications and what are the chances. Now, ideally, these complications should be explained to the patient in the antenatal period, because when the decision needs to be taken for this thing, for assisted vaginal birth, usually it is in the second stage of the labor when the patient might not be able to absorb all of the information completely. So it's very important that you discuss all of these things, all of the complication and possibility of having assisted vaginal birth to the patient prior into antenatal period. Now if you tell all of this thing, if you give the approach to the patient, and if the examiner sees this approach, I am sure they are going to be very, very impressed with your approach, and they know that this is a better doctor, and your chances of getting good marks is quite high in this time. Okay, now let's start with this thing actually. Let's talk about the episiotomy first. So examiner might want to ask you that, okay, whether it is important to give the episiotomy to all of the patient before going for assisted vaginal birth. The answer is no. Not all of the cases require episiotomy prior to vacuum and forceps. But we got the statistics. 90% for the forceps and 50 to 60% for the vacuum. So if the patient is going for forceps, yes, 90% of them is going to require episiotomy, while it is 50 to 60% with the vacuum. Vulvovaginal tear, obviously it is more common in the forceps, 20%. But it is not zero in vacuum, so it is 10% as well. Okay, now OASI, what that means? OASI means obstetric anal sphincter injury. OASI, obstetric anal sphincter injury, which is more common with the forceps. It is 8 to 12%, but vacuum is also having a 1 to 4% rate. Now comes the important part, PPH. Irrespective of forceps or vacuum, the patient is at high risk of PPH, and you should be having all of the things in your mind that, okay, this patient might go for PPH. You have to be prepared well for PPH. You got all of the things well settled with the PPH when you're going for assisted vaginal birth. Your team, the nursing team, the consultant, the neonatologist, the anesthetics, all of them should be aware of this thing, because it's very important. Now we got the common status for that. It is 10 to 40%. So assisted vaginal birth, the patients are at risk of PPH 10 to 40%. Okay, now the incontinence, it can be either bowel incontinence or it can be urinary incontinence. It is common. We don't have the exact figure, but it is common at 6 weeks, but it gets better with the time. Now cephalohematoma and retinal hemorrhage, both of these complications are more common with vacuum, and we got the statistics for that. Cephalohematoma more common with the vacuum, 1 to 12%. Retinal hemorrhage 17 to 38%, which is not a very good thing. Okay, so retinal hemorrhage is quite problematic complication, and you see the statistics, 17 to 38%. So vacuum is not at all very, very safe. Okay, Because some of the students think that, oh, vacuum is fine, forceps are not good. No, this is not the case here. So you have to explain this thing to the patient as well. Now, the fetal and scalp laceration. The fetal and scalp laceration are commoner with the forceps, but with the old studies and meta-analysis, we now know that both of them, either vacuum or forceps, have almost similar kind of lacerations. Okay, and the rate is 10%. Yes, some studies definitely see that the forceps are more common, but meta-analysis is not, favoring any of this vacuum or forceps. They say that yes, it is common with the both of the procedures, and it is 10%. Jaundice, neonatal jaundice. I used to think that the jaundice is more common with the vacuum, but again, as I say, it is almost similar, 5 to 15% in all of the cases. Subglial hemorrhage. It's common with the vacuum, and that is 3 to 6 per thousand. The rate is 3 to 6 per thousand. Intracranial hemorrhage, again, a very, very disastrous complication of assisted vaginal birth. The rate is 5 to 15 per 10,000. So if you explain all of this statistic to the patient, the educated patient, then they can take the decision that, okay, I want to go for vacuum or I want to go for forceps if it is needed. Now, you also, some of the institutions, they always go for the cesarean section because they don't want to take the risk with assisted vaginal birth. Now, again, as I said, cesarean section in second stage, where the fetal head is deeply impacted into the pelvis, cesarean section is also risky, and sometimes more risky than assisted vaginal birth. But the catch here is, for assisted vaginal birth, you need skilled people. Okay, sometimes the skill is missing. That's why most of the institutions and most of the departments go for cesarean section when it's time for assisted vaginal birth. So it's very important that the obstetrician and the clinicians actually learn to do the assisted vaginal birth, because going for the second stage cesarean section is not always easy. Number one, it is risky, maybe more riskier than assisted vaginal birth. So you have to decide which method got less risk, so you can advise this with the patient. Yeah, so this is all about in this video. We'll discuss more further details, and we'll further details about ObGyn in our next videos. Thank you very much.